Welcome back. So this is part 3 of our lecture on vaginal birth after cesarean section. And in the last part, we were comparing the benefits versus risks for the mother of either if we give a patient a trial of VBAC or if we perform an elective repeat cesarean section. So for the mother, we already discussed for the baby, for the neonatal outcomes. There is reduced risk of if we perform a vaginal, if the VBAC is successful, then the risk of transient tachypnea of newborn or transient respiratory morbidity is lesser compared to elective cesarean section. This is actually a major benefit for the baby. So why does it happen? It is said that when baby passes through the birth canal in while going through a vaginal a normal delivery, so the secretions in the lungs, the chest is compressed and secretions in the lung, they are expelled. Okay, so that helps reduce respiratory morbidity. However, this does not happen when we perform a C-section, right? Be it elective or emergency, and as a result, babies who are born even at term, and if there are otherwise no complications, sometimes unexpectedly after a C-section, babies develop transient tachypnea of newborn (TTN). Okay, and they may need to visit the neonatal unit. So, for after a cesarean section, risk of transient respiratory morbidity is 4 to 5%. Okay, the risk is reduced with antenatal corticosteroids, but there are concerns about potential long-term adverse effects. We already discussed that, and remember. So, usually elective repeats a planned cesarean section. If there are no other complications and baby's movements are fine, then it should be performed after 39 weeks, because although baby reaches a term at 37 weeks, right? But even after 37 weeks and early 38 weeks, babies can still develop respiratory problems. So it is best. But however, if there are some other indications, for example, if there is diabetes, then we do not wait till 39 weeks. And so, except diabetes, if there is no other complication, that women should be delivered after 38 weeks instead of 39 weeks. Okay. So, if, for example, if a case arises, many hospitals use this protocol that if there is a patient who does not has developed diabetes, and if for some reason she has to be delivered, say for example, even at 37 weeks, many hospitals they give antenatal corticosteroids. So that's separate from what we give between 24 to 35 weeks. Okay. So then for a planned VBAC, prospective risk of antepartum stillbirth beyond 39 weeks while awaiting spontaneous labor, right? So in the beginning, I told that there is a very small risk that if there was a previous C-section, there is a very small risk that baby may have a stillbirth without any other reason, okay? And and we already know that vaginal birth is more challenging for the baby. It's more risky for the baby compared to the mother. Okay, cesarean section, that's more risky for the mother. There are more likely to have, mothers are more likely to have complications compared to the baby. So with a VBAC, there is a small increased risk of having hypoxic ischemic encephalopathy, which means like hypoxia. Okay. There are 3 grades of HIE, but I believe you will learn about that in PEDS, so I won't go into that detail. Risk of delivery-related perinatal death. Okay, so because after a VBAC, we may have complications, especially for the baby. There may be shoulder dystocia, for example. Okay, and because of complications during labor and childbirth, there is slight increased risk of having perinatal birth, perinatal death. So it can also happen after a C-section, but the risk is very, very small compared to a vaginal a VBAC, especially if it becomes unsuccessful. Okay. So if we have a woman who previously had a C-section and we just kept waiting for her to go into labor, but she did not go into labor, then what should we do? Can we induce her? The answer is yes, we can induce her, but what method of induction should be used? We should not use medicines, like we should not use pharmacological methods. Usually it's prostaglandins, right? So avoid prostaglandins. Instead, how we can induce her? So either we can insert a Foley's catheter, not into the urethra, okay? This will go into the cervix. Okay, so what happens? The balloon of the Foley's catheter when it is inserted instead of the urethra into the cervical canal, and then the balloon is inflated and it is left there at least for 12 hours. Sometimes it's left even for 24 hours, but usually it's for 12 hours, and then it starts to dilate, the cervix starts to dilate, okay? And what happens if this fails, right? What happens if the cervical os is so we need at least some dilatation of cervical os even to insert Foley's catheter, okay? If it's tightly closed, then we cannot do it. And another option is if the cervix is slightly dilated, say for example 1.52 centimeter, we may be able to perform an artificial rupture of membranes, okay, and then let the woman go into labor. So these are the options, but do not use prostaglandins for previous C-sections because it increases the risk of hyperstimulation or uterine rupture. Okay, so if a woman is attempting a VBAC, so it should be one-to-one care, like one midwife should be constantly with her, and she should be appropriately counseled. It should be a suitably staffed, means we have adequate staff. It should not be like one midwife is looking after 3 patients. Equipped delivery suite means like we have a CTG machine. She should be having continuous monitoring of fetal heart rate. We should have easy access to an operation theatre just in case. If we see any signs of impending uterine rupture, then we have to immediately rush her to the operation theatre. Resources available for immediate cesarean section and advanced neonatal resuscitation. We can give her epidural analgesia. Epidural analgesia is safe, okay? But just remember, and maybe you remember from your lecture on labor, that whenever patients are given epidural, we have to catheterize them as well. Okay, the problem with epidural is one of the signs of uterine rupture is having a lot of pain initially. Okay, so if a patient is having epidural, that sign may be lost. So a few years ago, many years ago, actually, this was a bit debated whether they should be given epidural or not. But now there is general consensus, and they are given epidural. Okay. Supportive one-to-one care, intravenous access with full blood count and blood group in safe. So that means she should be ready, right? Because if she starts to have uterine rupture, she may have internal bleeding, right? She can go into hypovolemic shock, and as a result, we should have a recent hemoglobin level, a full, which is part of full blood count and group in safe, which means if she needs blood transfusion, it should be like at least the sample must have been sent. Continuous electronic fetal monitoring, which is CTG, regular monitoring of maternal signs and symptoms, which means vital signs, regular no less than 4 hour assessment of progress in labor by, like, we have to do digital vaginal examination at least every. But as we know that if there are any concerns, we can do it more frequently. So now what is the difference between a scar rupture and scar dehiscence? So now what is the difference? See, a scar is a weak tissue, right? See, it cannot, the elasticity is actually lost, so it's a weak. So if you just look at this picture, so it's a normal scar. This is the decidua, means the endometrium, and then these are the fetal membranes, the amniotic membrane, where it says, okay, like chorion comes first and then there is amnion. Like chorion comes first and then there is, and then the thickest part of the uterus is the, but when there is a cut on the anterior surface, that becomes a weak area. But when there is a cut on the anterior surface, that becomes a weak. So the difference between scar dehiscence and scar rupture is, in scar dehiscence, all of this myometrium that is lost. So the difference between scar okay, and now the only protection between the baby and the outer abdomen, right? Abdominal contents, like outside the surface of the uterus, is the, right? That's the peritoneum covering the uterus. Okay, so these are just thin layers, right? That's the peritoneum covering the uterus. Okay, so just imagine baby's life hanging just by, it is just there is no actual muscular layer. That's scar dehiscence, and scar rupture means even that is lost. There is no actual. So baby can, from the uterus, it can go into the abdominal cavity. If there is scar rupture, in dehiscence, it's still there, just hanging. If there is scar rupture, the life is protected. Now you may not find these images on your slides. I just added them. Now, you may not find one of the signs of impending uterine rupture is, now you can see how can we see blood in the urine. Now you can see how can we see blood in the urine. It's because if we have given the patient epidural analgesic, and then we have to, one of the important things we have to monitor is whether there is any streak of blood in the tubing or in the urine bag. Please remember that. It's very important to check the tubing as well. Okay, please remember that. Because initially it may be a little bit of this tinge of blood. If a patient is catheterized in labor, that's not a good sign. This tinge of blood, it means two things. It may be obstructed labor, or if the patient had a previous C-section, it may mean that she's okay. And if there is gross hematuria, that's a late sign, frank hematuria. Okay. By that time, maybe I don't know. Maybe the baby already passes away, and maybe patient is already in hypovolemic shock. So just even this one, maybe the baby. See if you see streak of blood in the tubing, that's a very dangerous sign. In general, what are the clinical features associated with uterine rupture? So first is always CTG. There are always problems with baby's heartbeat. Initially, usually baby, there is tachycardia, and then but all of a sudden, so it may be different, but there are always abnormal fetal heart rate patterns. Yeah, but all of a sudden, so it may be different. Okay. Severe abdominal pain. Initially, there is a lot of pain, and it will be continuous, and then once it has ruptured, these contractions, they go. So once the uterus ruptures, before rupture it contracts a lot, so it will be continuous pain, and then these contractions cease when the uterus. Acute onset scar tenderness. How do we do that? We just place our hand at the site where the previous C-section was performed, like on the lower part of the, just supracally, right? Try to distract the patient. Just try to ask, can you feel movements, something like that? Can you feel movements, something like that? Can you feel movements, something like that? And just slightly press it and see, by placing your hand, tenderness positive is a dangerous sign. Okay, so tenderness positive. So you may hear people on labor ward talking, oh, scar tenderness is positive or scar tenderness is negative. Abnormal vaginal bleeding, yes, that can happen. Abnormal vaginal, and strange enough, interestingly, actually, one of the reasons of postpartum hemorrhages. So what happens? The patient even delivers normally sometimes, but it can happen even in the second stage while the baby is being delivered. So what happens? The patient even okay. So one of the causes of primary postpartum hemorrhages is uterine rupture. Okay. And then, so what will happen in if there is PPH because of uterine rupture? The uterus will be, there will be no vaginal tears or cervical tears, but we know that it's just the patient is bleeding. So always consider it. Hematuria, we already discussed, cessation of previously efficient uterine activity, and then patient can have tachycardia, hypotension, fainting on shock. These are late signs because the patient is already in hypovolemic shock. These are late signs because the patient is loss of station of the presenting part. Means, say for example, initially if the baby's presenting part or head was engaged, that engagement will be lost. Loss of, okay, because once the baby is expelled into the abdominal cavity, everything is lost, right? And change in abdominal contour, so we can easily feel baby's parts because it is outside, so we can very easily, it's just under the abdominal wall. Okay, it is outside. And inability to pick fetal heart rate at the old transducer size means if we were performing a CTG, for example, if previously the baby's heartbeat was on the right lower part, right? For example, if previously, maybe now it's no, maybe it's now in the upper left side or even somewhere else. Okay, maybe it's now in the upper left side or even somewhere else. Okay. So if we plan to perform an elective repeat cesarean section, it should be, but for diabetes, we know that there is increased risk of stillbirth, so it's performed even if it is well controlled. Okay. So it is performed after 38 weeks. Okay. Antibiotics should be administered before making the skin incision in women undergoing elective repeat cesareans. Antibiotics should be administered before making the skin section. So in UAE, we give antibiotics even after a normal vaginal delivery or even after an episiotomy, or we give antibiotics, right? But in places like if you go for an international exam, do not say that postnatal oats. We don't do that. Okay, even after a C-section, they are not given like routinely. They are not given like routinely. They are not given like routinely. They are, but this antibiotic just before skin incision in the operation theater. okay, in the operation theater. So who gives it? Anesthetist gives it. Okay, so who gives it? Anesthetist.